taking hormone replacement. So those are the biggest risk factors for developing breast cancer. But there's also some inherited risk factors, so some things that we get from our family that we just can't change. And those are family members who, or personal history of having breast cancer before 50, anyone who's had bilateral breast cancers. So we know that having one breast cancer is bad luck. About 1 in 8 women will have breast cancer, but having breast cancer in both breasts is a sign that you may have a genetic mutation which caused you to get the breast cancer. Men with breast cancer are also increased risk for having a mutation in any of their family members, as well as ovarian cancer, because ovarian cancer is such a rare cancer that it's associated with the BRCA mutation. And then also, as we know, multiple generations, so not just a grandmother, but if your grandmother and your mom and your sister or so have breast cancer, these are people who need to be tested for a genetic mutation, and those of Ashkenazi Jewish descent as well. So you'll see going through my talk, I like to take pictures of breast in nature. So these are cactus that I saw in Phoenix. And there's some questions recently about what are the recommended guidelines and when should people be screened for breast cancer. We know that early detection is the best thing we have. Sometimes mammograms feel like this, but if a picture can save your life, then it's worth getting your mammogram once a year. The guidelines I like to talk to my patients about are really just getting to know your body. Know if anything changes. Look at yourself in the mirror when you get out of the shower so that you know if your breasts are changing shape, if you have any dimples or anything that changes. The recommendations from most cancer societies are to start at 40. But that's a little, if you have a family member who had breast cancer early, then we should start 5 years before then. And discussions can be had with your physician as to whether or not you should start at 40 to 45, but most say to start at 40 and then do them every year. And that's the recommendations from the American Society of Breast Surgeons. Once again, not like the picture, but if a picture can save your life and we can get our mammograms done, then we should get them done. I tell people it's not really the pressure on the breast. For me, it's more of the tugging and pulling, and that's a little odd as they position your breast in the mammogram machine. But it really, we do many things in our life that are uncomfortable, so a mammogram shouldn't prevent us from being able to save a life. Here's some coconuts from Jamaica. All right, so you go and get your screening mammogram, and then what happens? Well, if we see something abnormal, then we order additional tests, like a diagnostic mammogram, an ultrasound, or an MRI. And then if needed, if we still see something that makes us concerned, then we order a biopsy. The biopsies are usually done 2 ways. One is an ultrasound, and the other is a stereotactic. We can do an MRI-guided biopsy, but those are for really hard to see abnormalities that we just can't biopsy any other way. And we know that early detection is the key for survival. In 2017, there's proposed to be 252,000 new cases of breast cancer. Of interest, there's about 25,000 of those that are going to be diagnosed in women less than 45. So the new cancer guidelines of not getting mammograms until 45 would miss all of those women who could be detected on mammography screening before they can feel a mass. For women older than 65, you'll see about half of our breast cancer cases in the U.S. will be diagnosed over 65. And along with those numbers that we just mentioned, about 63,000 of new cases of in situ cancer. So these are our stage 0 cancers that can't even spread, that are just located within the breast that can be treated locally. I'm sorry, my apostrophes or my comma here is a little different, but there's 41,000 deaths in the U.S. for 2017. So really the good news is that only 1 in 35 women who get breast cancer will die of the disease. And breast cancer death rates are down 36% in the last 15 years. And the reason I do this is because there are now more than 3 million breast cancer survivors. So that means 3 million women have breast cancer as part of their medical history, no longer undergoing treatment. So this is what we do, is to make survivors. We know currently survival is still based on stage, so if we can diagnose people in stage 0 or stage 1 who have a mammographically detected cancer before you can feel a lump, that those survival rates at 5 years are still 93% survival at 5 years with early detection. So what happens after the diagnosis? So, we talk about trying to decrease that amount of time between your abnormal mammogram to diagnosis because, unfortunately some women who are diagnosed, we want to decrease that and give the women who aren't diagnosed with cancer some a breath or sigh of relief that they don't have breast cancer. But on occasion, we still diagnose people with the breast cancer. And this is a nice chart that I break up and try to walk through patients, or walk patients through when we talk about treatment. And so we know you've got the diagnosis of cancer. Now how can we treat it? So I break it into 2 different areas. The first is systemic treatment, which is truly what changes survival in breast cancer. And systemic treatment has chemotherapy, hormonal therapy, and targeted therapy. So we're really trying to individualize and personalize treatment for each specific cancer. We used to think that breast cancer was breast cancer because it started in the breast. We now know that there's many different types of breast cancer, and each one needs to be treated individually. We combine that with local treatment and what the patient wants to do with her breast. This is a personal choice and has nothing to do with the systemic treatment. So the local treatment, we had 2 options. We can either save the breast or do a mastectomy with or without reconstruction. And so who goes first? Do we have surgery first, or do we do chemotherapy first? And this decision should be made with a team of physicians, and so here I discuss all of my patients every week with this team, which includes the radiation oncologist, the medical oncologist, the radiologist, plastic surgery, pathology, and myself, along with all of our support staff and patient navigators and nurses and radiology techs. And all of us come up with a plan that we then present to the patient to provide what we think is the best choice. But at the center of this is always the patient. So we provide what the options are, and then it's truly up to the patient to decide what option they want to have. One of the biggest questions that the patient asks is, to chemo or not to chemo? When do I need chemotherapy? And we know that the treatment for the whole body is what's most important, as I mentioned earlier. And when we say chemotherapy, often we mean really 3 different areas. We talk about hormonal treatment, which is usually given with just a pill every day, and it targets hormone receptors on individual cancers. Or immunomodulators. So our oldest immunomodulator is Herceptin, which we give for HER2 positive cancers. And then chemotherapy is the traditional IV type of chemotherapy where patients come into the infusion center. So all of these go in as to systemic treatment and treatment for the whole body. But how do we make these decisions? Traditionally, whether or not lymph nodes were involved was the traditional indication for systemic treatment. But as we looked through our practice, we realized that treatment's often given regardless of the axillary status. So it's always given for hormone receptor negative patients, for HER2 positive patients, young patients, and large tumors. So really our systemic treatment was very variable. And so thankfully now we have a couple of tests, the Oncotype test as well as the MammoPrint, and a couple other branded tests that look at 21 different genes in a cancer to tell us if the patient or the tumor would respond to chemotherapy. So we try to look at prognostic and predictive markers. These prognostic markers tell us the risk of recurrence. Some of those that we know are the tumor size, whether or not it's or whether or not it's spread to the lymph nodes, the histology and the grade of the tumor, whether it's involved in the lymphatics, the patient's age, estrogen, progesterone receptors, all of these things that we look at on the pathology report, as well as the patient's history, tell us if this is a high risk for recurrence or a low risk. And then we look at prediction. Can we predict who would get a benefit from chemotherapy or hormonal therapy? And like I said, thankfully now we can do a test on each specific cancer so that we are really personalizing care, not only for the patient, but for the cancer. Most of these tests come back and they give us a recurrence risk. So then we can actually give data to the patient and talk to them about what's your risk of recurrence at 5 years or 10 years. You know, some of our patients say, I would take chemotherapy for a 1% benefit, and some patients don't want chemotherapy for a 20% benefit. And it's all about, you know, what the patient wants and what their goal of life is. If you can see my slides, this is the recurrence risk score. But basically what this tells us is these are all the proliferation markers, the cancer genes that go into a formula to let us know if this cancer would respond to chemotherapy or not. And we know this is important, so this is actually going to be added into our cancer staging guidelines. We're coming out with the 8th edition next year. And we know that this genetic information and personalizing cancer care on individual cancers is very important. No longer is the old-fashioned way of staging cancer and giving prognosis based on the size of the tumor and whether or not the lymph nodes are involved. It's really important for us to know the genetics and know the specifics of each cancer so that we can offer the best treatment options. Here's another slide of a phoenix cactus. Let's see. So once we go through all of these options with the patient about what they want to do or whether or not chemotherapy would benefit them, then we start talking about surgery. It's hard when you talk to patients for the first time to see if, you know, everybody wants to know, what are we going to do with my breasts? What kind of surgery am I going to have? But oftentimes it's better to take, you know, a few days, a week, sometimes 2 or 3 weeks to gather all of this information to patients. I tell people that often it's a mental emergency when you find out that you have cancer, but not really an oncologic emergency. So if we need to have genetic testing back, if we need to run these oncotype tests or mammoprint tests on patients before we start treatment, then it's okay. We can order these tests and get all of our, you know, ducks in a row before we come up with a plan so that it's the best plan for the patient and for their family. But surgery, what kind of surgery should we do? Is bigger surgery always better? Well, William Halsted said it was. Back in 1907, he said that cancer starts locally and extends continuously and spreads through the lymphatics, and that the nodes act as a barrier. And this was, you know, standard of care for the next 75 years. So this is the way that most of our grandparents were treated, with a radical mastectomy. And the thought was that if we can get far enough past the cancer, then we can save these patients. You know, so we did horrible surgeries to people. We took off their whole breast. The picture here I'm showing is a picture of a nun where the breast was removed and then cautery used to stop the bleeding here. But maybe we can save the breast. This was the thought about from Bernard Fisher with NSABP, which he proposed that the cancer spreads through the lymphatics in the bloodstream, and that many breast cancers are systemic even when they're small and early on in their disease. And also put out a radical thought that maybe the nodes are not an effective barrier. And we know this today because we know that breast cancer survival is the same, whether a patient wants to save their breast or proceed with a mastectomy. It's truly a personal choice. And so how can we do this? How can we save a patient's breast or offer them a mastectomy? Many patients still think that a bigger surgery is better. But through breast conservation, we have made several improvements. Traditionally, women had to go in, come into surgery the morning of, go down to mammography, have a wire placed into their breast where the cancer was if we couldn't feel it. And then they'd have to go from mammography, where they were awake for this procedure, come to the operating room, and we'd have to follow this wire down and take out part of the breast. This was uncomfortable for the patients. Many patients have a vagal response and actually get nauseated or pass out from the wire being placed in their breast. And then it wasn't very easy for us as well. So scheduling issues, lots of operative delays, having patients go down the morning of surgery, have this needle placed in their breast, and then brought to the operating room. Thankfully now we can do needleless localization. These can be done up to 30 days ahead of time. We can use an ultrasound for larger tumors or a mammography for smaller ones. And we can either place a radioactive seed or a reflector called a savvy scout. And there are pros and cons of each of these, but the point is that these can be placed ahead of time so that patients don't have to go through the localization and the surgery on the same day, as well as it's easier for the whole hospital system and the operating room to get patients in on separate days so that they can come in and not have a wire sticking out of the patient's breast. Surgery is done about the same way. The patient comes into the operating room the morning of surgery, and then I use a localization device to either find the radioactive seed or the scout. And pictures are taken after the specimen is removed so that we can ensure that we have removed both where the clip was placed and then either the seed or the savvy scout reflector. And we know that breast conservation is safe. The NSABP trials that I mentioned earlier were done, we recruited patients between 76 and 84 and found that there was a 12% recurrence rate for lumpectomy with radiation versus a 53% recurrence rate for lumpectomy alone. So we have to remember when we talk to our patients about breast conservation or lumpectomy, partial mastectomy, all of those terms I use interchangeably, we have to remind them that if they want to save their breast, then we still have to add radiation. And radiation helps the surgeon by extending our area, basically that we operate on, by either adding local radiation or whole breast radiation to decrease the risk of the cancer coming back within the breast. Traditionally, radiation was done, 30 treatments usually over 6 weeks. A patient came in and laid on the radiation table, was positioned in the same manner every day. Treatments don't take very long, but the patient had to come back every day for 6 weeks, Monday through Friday. And we did external planning, so we have to remember to tell our patients that radiation treatment has also come a long way. Some of our patients remember their family members having radiation where we used to just do radiation that shot all the way through their chest. So it would damage the lungs and the heart, especially on left-sided breast cancers. We've improved our techniques immensely so that now we can provide tangential beams of radiation so that the beams are shielded away from the heart and the lungs. But in addition to this, now we can do radiation for some patients in 5 days. We can do 5 days, twice a day. There are some restrictions as to who we think are good candidates for this. Most of the guidelines say that patients should be over 50, have small tumors, and of course negative lymph nodes. But now we can either place a catheter into the breast and then put the radiation actually inside the breast tissue itself to add that radiation around where the surgical cavity was to really increase our margins from surgery and to decrease the risk of recurrence in the breast. But this is a good choice for women who, like I said, meet those guidelines and really want to do their radiation in 5 days instead of 6 weeks. This is a picture in my backyard of some flowers that reminded me of breast. Some women don't want to save their breast. Either it's inconvenient for them to come in for radiation. I know when I was in Lubbock, these women drove an hour to 2 hours to come in to the medical center there, and so to tell them that they had to then come back every day for 6 weeks, thankfully we had the American Cancer Society's Hope Lodge, but not every community has that. So even here in the Houston area, it's hard for women to come every day for 6 weeks if they're not a candidate for the 5-day treatment to have the radiation. So then our option is mastectomy. Most women, when you say mastectomy, think of this picture that I'm showing here. And this is a patient that I took care of when I was a fellow in Arkansas. And you can see this is a radical mastectomy. Her pectoralis muscle is removed. You can see her ribs there. And really that arm is then useless because they used to take out sometimes even the axillary vein and the nerves along with the lymphatics underneath there. So we have come a long way with mastectomy. This is a modified radical mastectomy here where we leave the muscle, but some women don't do reconstruction or aren't offered reconstruction at the same time as mastectomy. So this is, once again, why it's important to have a team approach so that everyone can work together and we can offer patients reconstruction at the same time if they choose for their treatment. But once again, mastectomies and reconstruction have come a long way. And so this is a patient who had a cancer, had small breasts, and wanted larger breasts and reconstruction, and had implant-based reconstruction. So implant-based reconstruction is usually a silicone implant placed back behind the muscle. It's a 2-step process, meaning that expanders are placed at the time of mastectomy, and they're placed back behind the muscle, and then they go through an expansion project. It sounds like we're talking about a house here, but they go through expansion weekly so that then their skin pocket can accommodate a bigger implant. And so then it's a day surgery to take those expanders out and put implants in. We can also use your own tissue. So the most common that we use here in Katy is a deep flap. And so that's a flap that takes the fat from the abdomen along with the pedicle, a blood vessel. And so we can recreate the breast with fatty tissue from your abdomen. And that's called a deep flap, which is an improvement from what we used to do with a tram flap, which was a muscle flap from the abdomen, which then came with problems from hernias and abdominal surgery caused by removing the muscles of the abdomen. So really, women have a tummy tuck along with reconstruction of the breast. And what about saving the nipple? We hear a lot about, or women come in and ask if we can save the nipple. And I tell everyone that we don't always save the nipple. We can save the skin overlying the nipple, but it is truly an oncologic procedure where the ducts are removed all the way up to the skin from the breast. And so this is a useful procedure if women have nipples where, or if your patients have nipples where they are supposed to be, or where they'd like them with reconstructed breast. So it's not a candidate, not everyone is a candidate for this surgery. The breasts have to be of a good size where we can reconstruct with the pocket of skin that they have, so not too big, not too small. The tumors have to be less than 2 centimeters, have to be located away from the nipple, and then no nipple discharge because we're afraid maybe that skin has been seeded with cancer if they present with nipple discharge. And we always do a frozen section from behind the nipple when the patient's in the operating room to make sure that there's no cancer remaining from behind the nipple. But bilateral, I say total skin sparing or nipple sparing mastectomies are a good option for some women who have cancer. And I would say the most common time we do this is for prophylactic surgery for women who are high risk, maybe with the BRCA type mutation, who are younger with kind of average sized breasts who want to save the nipple there. And so it's a good option to be able to offer them that. This is another picture of lighting that reminded me of breast. And that's about all I have. I kind of kept it short and sweet so we could have questions and interactions if anyone had anything.
If anybody has questions,
anyone have questions?
Into the chat box. Looks like we had somebody typing.
Good.
So it says, are expanders needed even when going down a size from normal breasts?
Most of the time, because the expanders are placed usually behind the muscle, we're not only stretching the skin, but also the pectoralis muscle to accommodate the implant back behind there.
Are you seeing recurrence in patients on HT?
Let's see, are you seeing? On hormone therapy, so the recommendation, the NCCN guidelines are that patients go off of hormone replacement therapy when they're diagnosed with cancer. So if a woman's on hormone therapy, then they should be taken off of that, as well as birth control. So then we need to talk about other birth control type options. The most common one I use is a copper IUD with my patients so that they're not getting the estrogen progesterone. And so, but yes, I think anyone can have a recurrence, but we shouldn't be feeding the cancer by continuing the hormone therapy, which makes those side effects as to why women are on hormone treatment worse, because not only are we taking them off of their hormone replacement therapy, but then also usually adding an anti-estrogen like Arimidex or tamoxifen on top of that. And so we do have patients who suffer then from those side effects, probably a little worse if they're used to having that estrogen and progesterone in their system, because we've not only stopped their hormone replacement, but also really turned off anything else that was making in their adrenal glands or the conversion. Speaking of Arimidex, so patients who are on anti-estrogen therapy already, we do see that. Many studies have looked at whether or not people should be on tamoxifen or Arimidex for 5 years versus 10 years. And most studies have shown that 5 years in postmenopausal women is equal to 10 years. We are giving tamoxifen to premenopausal women now for 10 years is the recommendation. But estrogen and progesterone positive cancers, when we look at recurrence risk, these type cancers are the cancers that come back or can come back many years later. It's not unheard of to have these patients who were treated with ER&PR positive breast cancers have a recurrence 15, 20 years down the road, which is very different from our triple negative cancers, which usually recur within the first 3 to 5 years if they're going to recur, and then their risk of long-term recurrence is usually very low.
While we're waiting to see if there's any other questions, there's your certificate of attendance is back on that files box on the bottom left corner, so click on certificate of attendance and download it, and there it is. If you're only on the phone, feel free to send me an email and I will send it to you. Do you have any other questions? Okay, guess not. Thank you everybody for joining, and thank you especially for Dr. Arentz.
All right, well thank you very much for having me.
If anyone has more questions, feel free to email me and I can pass them along. But thank you to everybody who joined in. Have a great afternoon.